So now we are going to learn about hypertensive retinopathy, which is very important. It can come as a short answer question, can also come as a long answer question. So what is hypertensive retinopathy? So it is nothing but the ophthalmic findings of the end organ damage secondary to systemic hypertension. Okay, it affects the precapillary arterioles and the capillaries. Then due to uncontrolled systemic hypertension, what happens? There is non-perfusion at various retinal levels and there is neuronal loss also. So both the nerves as well as the blood vessels are affected in hypertensive retinopathy. Okay, so let's start. So what is the pathophysiology of hypertension? So whenever there is arteriosclerosis, there is breakdown of the autoregulation. There is breakdown of the whatever is the blood cycle of the retina, there is breakdown. So what will happen? There will be higher pressure in the arterioles. Because of the arteriosclerotic changes, the pressure will rise. This pressure will be transmitted to the capillaries. Okay. So either there will be capillary closure or there will be hemorrhage. So what actually happens? There is narrowing of the retinal arterioles. Due to narrowing, the blood supply will be compromised. When the blood supply is compromised in the retina, there will be retinal ischemia. There will be hypoxia. So what happens? There is increase in the vascular permeability. When there is increase in the vascular permeability, so what things will happen? What pathological things happens? So first is retinal hemorrhages. Depends upon at which level the vascular permeability is increased. If it is at the superficial level or at a deeper layer. The superficial capillary plexus is affected. So there will be hemorrhages which are flame shaped. That is just like the flames of the fire. The hemorrhages will appear in the same shape in the retina. If the deeper capillary plexus is affected, that is in the inner nuclear layer, so what will happen? The hemorrhages will be dot and blot, that is dot hemorrhages, dot like reddish spots will be seen of hemorrhages in the retina. Or there will be exudation, smaller exudation and a larger exudation. If there is a larger exudation, there will be exudation in the subretinal space leading to retinal edema. If there are smaller exudation, if the exudation is present at the level of nerve fiber layer, what will happen? There will be extension of the size of the axon, which are called as soft exudates, and hard exudates will be present in the plexiform layer. Okay. What are the clinical features? Either the patient will be asymptomatic, and just by the fundus finding we will see and we will diagnose that it is a hypertensive retinopathy, or patient will come with headache. Headache is nothing but a feature of systemic hypertension. The blurring of vision, if the macula is involved, definitely there will be blurring of vision. Sometimes patient will have a transient vision loss, that is sometimes the patient is seeing clearly, sometimes there is blurring. Now what are the different changes in hypertensive retinopathy? So there are focal arteriolar narrowing and arterial venous nicking and sclerosis. Changes we will see, arterial changes we will see later. Then there are flame shaped hemorrhages if the superficial capillary plexus is affected. There will be blot hemorrhages if the deep plexus is affected. And there will be microaneurysm also. There will be hard exudates, that is if there is exudation in the plexiform layer. Cotton wool spots if there is exudation in the nerve fiber layer. Then optic disc swelling will also be there. So see this figure. What are the different changes in the hypertensive retinopathy? First of all, we will see the arteriovenous changes. So you can see the wall of the venule and the wall of the arteriole, and you can see the blood column. Okay, this is a normal arteriovenous crossing. But what happens here? Whenever there is arteriosclerosis, what happens to the wall? The wall of the arteriole is thickened, and there is appearing of the reflected light, silver or copper wire. Just like silver or the copper wire, the reflection of the silver or the copper wire, the walls will also give the similar reflection, okay, which is called as silver wiring or the copper wiring of the arterioles. When will this happen? Whenever there is a arteriosclerosis. Now let's see what happens to the nerve fiber layer. This is a normal nerve fiber layer. We can see the ganglionic cell and the axons of the ganglionic cells. What happens? Due to the exudation will enter the nerve fiber layer and the axons will become swollen in the with the intracytoplasmic bodies, and due to the swollen part they will appear as a cotton wool spots. Okay, see here, hemorrhages are there, there is a cotton wool spots, there is edema of the optic disc, AV nicking. What is AV nicking? I'll tell you later. Then there is macular star, that is there is retinal exudation, especially in the macular area, giving rise to the star-like appearance at the macula. Now there are AV crossing changes. There are three types of signs: Salus sign, gun sign, and the bonnet sign. This is, first of all, I'll show you something. See. So this is a normal AV crossing. Now what is gun sign? At the crossing of the arteriole, the ends of the, if you see the ends of the veins, see this figure, the ends of the veins where the arteriole has crossed, have become tapered. So this tapering of the ends of the veins at the arteriovenous crossing is called as a gun sign. Okay, this gun sign is present in stage 1 and stage 2 of hypertensive retinopathy. Now what is Salus sign? Salus sign is the vein become deflected at the AV crossing. Deflected means it changes its path, or it becomes curved or angulated. Okay, so that is the Salus sign. Now what is a bonnet sign? Bonnet sign is the other end of the vein in front of the distal to the arteriovenous crossing will become what? That end will become dilated and the blood will become stagnated there. It is called as banking. Okay, it is also called as a bonnet sign. Okay, that was about the signs. So let's see. So if you see the arterioles, there is a wiring, copper wiring of the arterioles, and if you see the veins, what has happened to the veins? You can see this, there is tapering of the veins. Salus sign is present. See here, gun sign or the Salus sign is present. The bonnet sign is also present if you see this carefully. If you see this figure, if you see the dark area of the vein here where there is stagnation of the blood at the distal end of the AV crossing, that is called as a bonnet sign. Okay, and if you see here at the AV crossing, what has happened? The vein has become angulated. Now next is, what are the classifications of hypertensive retinopathy? So first is Keith, Wagner and Barker classification. So it is divided into three grades. First is mild to moderate narrowing of the retinal arterioles. Grade 2 again has three subtypes. First is moderate to marked narrowing of the retinal arterioles. Along with that, there is copper wire reflex. It will give a shining copper wire reflex. What will give a shining reflex? Arterioles. Then typical AV crossing changes. Whatever changes we have seen, any one of the change or all three of the changes will be seen at the AV crossing. Then grade 3 is retinal arteriolar narrowing and focal constriction. Along with that, there will be silver wire appearance where the sclerosis is very much extent. Instead of copper wire reflex, it will become silver wire. Then there will be retinal edema. We have seen what is macular star will be seen there. Then cotton wool spots will be there, or soft, it is also called as soft exudate. Then superficial flame shaped hemorrhages will also be present. Okay, so this is a grade 3. Now what is modified Sky's classification? So in this classification, first is grade 0, that is no changes are seen. Grade 1 is barely detectable arteriolar narrowing. So if we compare all the arterioles, one of the or few arterioles will be seen narrowed. That is grade 1. Grade 2 is obvious arteriolar narrowing with focal irregularities. And grade 3 is grade 2 plus hemorrhages and or exudates. So along with the arterial narrowing, there will be hemorrhages with or without exudates. Grade 4 is grade 3 plus disc swelling, that is papilledema. Okay, papilledema is optic disc swelling, where how will we see papilledema? All the disc margins, temporal, nasal, etc. will be seen blurred. So if you see this, can you see the disc margin centrally? We can't see the disc margin. This is called as papilledema. If you see the hemorrhage, there is a this is a flame shaped hemorrhage. Okay, this is papilledema. Then there are hard exudate. There is cotton wool spot, just like a cotton wool appearance, that is just present in the nerve fiber layer. Then hard exudates, these are not exactly very clearly seen, but you can see it in your Khurana. Now what is hypertensive choroidopathy? So it typically occurs in the younger patients as an episode of acute hypertension associated with preeclampsia, eclampsia, pheochromocytoma, or renal hypertension. So whenever there is hypertensive choroidopathy, we must rule out these causes also: pheochromocytoma, renal hypertension, etc. Then what is Eschling spot? These spots are present whenever there is non-perfused choriocapillaries. Then there is cigarette streak, which is hyperpigmented streaks. This is not important. Just hypertensive retinopathy is important for your UG level. These are the Eschling spot. This is important. What is pregnancy-induced hypertension? It can be asked in your viva if you get if examiner asks you. So what is pregnancy-induced hypertension? It is a hypertension which is present in the pregnant women after 20 weeks of gestation. What is the symptom? There will be rapid or sudden weight gain, high blood pressure, proteinuria, then swelling in the hands, feet and face. It will be usually a pitting pedal edema whenever there is PIH. Okay. Then patient will have blurring of vision. There will be spots in front of the eyes which do not resolve, which could be due to retinal hemorrhages also, which could be due to retinal edema also. Okay. Then it is related to the vascular endothelial dysfunction. Also, when there is exudative retinal, there can be exudative retinal detachment. That is, if there is exudation in the subretinal space, due to that exudation, the retina will become detached. What are the risk factors of PIH? It is present if there is pregnancy under the age of 20 or over the age of 35. Patient has a history of chronic hypertension, or patient, this is a second or the third pregnancy and the previous pregnancy patient had hypertension. Then if the female relative has a history of PIH, then if the patient is underweight or overweight, that is in short a high risk pregnancy. Then if the patient has diabetes before becoming pregnant, then if the patient has immune system disorders such as lupus or rheumatoid arthritis, if patient has kidney disease, if patient has a history of alcohol, drug or tobacco abuse, or if the patient is expecting twins or triplet, then also the patient can be a high risk factor for pregnancy induced hypertension. Okay, PIH can also come as a short answer question. Hypertensive retinopathy overall can come as a short answer question. If it comes as a long answer question, you also have to mention PIH. Now what is the treatment? For grade 1 to 3, control of hypertension. Till there is papilledema, we can just control the hypertension. If the papilledema occurs, then it becomes a malignant hypertension. That is uncontrollable hypertension. Then that is uncontrollable hypertension with the conservative management. Then what we need to do? We need to apply a laser photocoagulation to resolve the hemorrhages. Or to resolve the edema, we have to do some retinal surgery. Okay. When there is PIH, we have to do a regular fundus examination. If there is a retinal hemorrhage, then what we do is we ask the patient either to control the hypertension first and then go for the surgery, or we usually ask the patient to terminate the pregnancy by cesarean and not by normal vaginal delivery, because with the increase in the intra-abdominal pressure, the increased intraocular pressure can also lead to hemorrhages, more and more hemorrhages. Sometimes there is even vitreous hemorrhage in the patients. So this is all about hypertensive retinopathy.